Welcome to the Pot of Inquiry, everyone. My guest today is Dr. John Cozzarelli. Dr. Cozzarelli is a very accomplished podiatric surgeon and podiatrist up in New Jersey. He happens to, by way of training, also be a registered pharmacist. And today he's going to talk about hyperuricemia and gout. Now, don't think that's going to be boring because he really gets into the metabolic effects of increased uric acid and why it is something that is so important. And actually, if you think about it, gout may be, and this may be crazy as I say it, one of the least of the problems that the patient with hyperuricemia really has because of all of the things that he lays out. This is something that you really want to take some time and think about. And when you go and have your next lab tests, make sure that they look at your uric acid level, even if you've never had a symptom of gout, because it's so much more than that. So please enjoy this great conversation that I have with Dr. John Cozzarelli.
Welcome to the Pot of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
Welcome to the Pot of Inquiry, everyone, the podcast for human optimization and understanding. And I'm really excited about my guest today, Dr. John Cozzarelli. And John presented some of this at the recent Georgia State meeting. And I was fortunate enough to catch this lecture, and I thought it was just wonderful. So I asked him to come on the show and share it with you all. So, John, thanks a lot for coming on.
Oh, no problem, Steve. I'm glad I could do that.
Yeah, no. And you're up in New Jersey, right?
Correct.
All right, very good. So what made you get into this topic of hyperuricemia and gout? Because it's a very unusual pathway, and I don't think anybody's really gotten into it like you've gotten into it.
Well, this is what you really find out. You know, you go back to our education, we had a 45-minute lecture in school about gout, and okay, yeah, I understand it. The truth is, the more you learn about gout, the less you understand about it. And unfortunately, it takes you back to, biochemical pathways and on a cellular level to really understand this disease state. And it's just, once you start to research it and understand it, you're like, this is incredible that uric acid is creating all this metabolic dysfunction. Mm-hmm. And I mean, there's some pioneers out there like David Perlmutter, Richard Johnson. They've written books on this topic now, and I encourage people to read it. Yes, I've read the traditional Turkel Kalb and Lawrence Edwards book on gout. These are reference books, but to really understand how we get this train to crash, you have to understand hyperuricemia.
Right. Yeah, I think Perlmutter wrote a book recently called Drop Acid.
Correct.
Yeah, it was a good book.
Great book.
Yeah.
Because he enlightened a lot of people, and I encourage people to read that book.
Well, if you look in history, gout might be one of the earliest talked about metabolic diseases.
Correct.
It's very interesting. I mean, famous kings were willing to give up their whole treasury, so to speak, to get rid of the agonizing pain.
So there was a book written in 1969, Yudkin, and it's called Pure, White, and Deadly. And it actually talks about sugar and how sugar, became a commodity of the rich. And, this is eventually they start to suffer from gout. You look at these societies and cultures that never had sugar in their diet, and you really start to understand it's more detrimental, than alcohol when you really understand everything. But you're 100% correct. I mean, if you go back with the history, and I realize that's not what we're talking about, but I'll go off on a little tangent. The word gout comes from the Latin word gutta. What does it actually mean? It's an ancient system of medicine, Hippocrates' time, and there were 4 humorisms, and it's dropping of bad blood. One was phlegm, one was yellow, one was black, but gutta actually means the dropping of bad blood.
Interesting.
And even when you look at medications like colchicine that we use for flare management, where does that come from? It comes from the crocus plant. It's over 2,000 years old.
So a lot of people think about hyperuricemia as only causing gout, but as Perlmutter and Richard Johnson and all these, luminaries, so to speak, yourself included, it's a much more wide-ranging systemic issue than just a painful big toe joint or a painful
Correct.
ankle. And
Correct.
so I hope, you're going to show us some of your presentation today, which I
Sure.
thought was great. And we'll get into that. And I think that if somebody, the listeners that, follow this along, I think that's going to be one of the things that they get out of this, is that we're not just talking about the application of hyperuricemia to gout, but overall health. And I love the fact of the way you drew out things from the metabolic pathways. So let's go ahead and get into that if you
Great.
want. All right.
So can we share some slides, Steve?
We can, if I'm technologically proficient, which usually I'm not. So I click the button. You should be able to go with it.
Okay, that is. So we call this lecture Hyperuricemia, Follow the Yellow Brick Road. And it basically goes like this. Yeah, I had some disclosures. I speak for Amgen. I speak for Universal Medical Systems, which is ultrasound imaging. But we have three simple objectives when we talk about this: to understand the systemic nature of hyperuricemia, recognizing that early diagnosis and early treatment results in better clinical outcomes. But the key to this whole lecture is understanding the biochemical pathways, because if you understand that, you don't have to memorize anything. It just flows. So this lecture I call the why. This is all why. You just don't memorize things. So I want everyone in the audience to think outside the box today. And the one thing that we're taught in school when we become doctors is that hyperuricemia is asymptomatic. I think by the time I'm done with you, I'll at least make you think about that. So when we look at this asymptomatic disease, the incidence, we have 71 million people in the United States in 2024 that have asymptomatic hyperuricemia. The reason that's a very interesting statistic is because in 1993, the AMA pulled uric acid out of the chem screen panel, out of sight, out of mind. So you start to think about this. This is a lot of people walking around the United States. Now, out of that 71 million people, 20% of them will end up with gout. So really what we're talking about is soluble uric acid becoming insoluble. But, I was asked this question one time in a lecture: what is the role of uric acid? And this is at a point where I did about 200 lectures. And I had to pause for a second and think about this. And I said, well, it's a catabolic end product. It's a waste product. It has no function. And that's really what started, because what happened is when I got home that night, I said to myself, is it really just a waste product? I'm not sure. And that's literally how I delved into this thing and went back over biochemical pathways. So what do we know? In December of 2024, they basically told us that it's considered a new metabolic marker for type 2 diabetes and metabolic syndrome. With metabolic syndrome, what I find interesting with that is that for every 1 point increase in serum uric acid, it increases the incidence of developing metabolic syndrome. So we look at this. It's a predictor for hypertension, obesity, CKD, non-alcoholic fatty liver disease, and type 2 diabetes. This is an incredible slide. And you don't have to memorize anything on here. You look at this. Greater than 50% of gout patients on average have 3 to 4 comorbidities. So we were taught in school that uric acid, when we look at this, gout is either overproduction, under excretion of uric acid. What we really know is it's driven by the kidneys 90% of the time. We know that when patients get to stage 3 kidney disease, the incidence of developing gout at that point is roughly 30%, and it becomes higher. Hypertension is the one you really have to understand. And this is what, we talked about, Steve, that when we look at hypertension, you have to go back to that pathway again. So we intake salt. What happens when we intake salt? It's real simple. We secrete vasopressin. We know what that does. It constricts our blood vessels. Our blood pressure goes up. We retain extracellular water because we're pretty much going into survival mode at this point. And the next thing that happens is that stimulates aldoreductase. Once that's activated, that kicks off fructokinase. And fructokinase is interesting because there's no shutoff mechanism with this. So once it's activated, the end product that fructokinase produces is endogenous fructose. So you intake salt, you end up with endogenous fructose. What's the breakdown of fructose eventually? Uric acid.
Right.
Wow.
Right.
Okay, so where is, uric acid? I'm sorry, where's fructose metabolized? The liver. So we look at this. Hyperlipidemia. Is this a surprise now? Absolutely not. So once that gets into the liver, you create this visceral fat, lipogenesis, and your dyslipidemia, your triglycerides go up. When we look at CKD, we talked about that. With nephrolithiasis, that's even interesting. We're taught in school that 80% of the time it's calcium oxalate, 20% of the time it's uric acid. What does the new literature really tell us? That it depends how the stone is sectioned. If they do an axial slice, what do they see? Calcium oxalate. If they do a coronal cut in the stone, what do they see in the center of that via DECT imaging, dual energy computed tomography? Guess what? Uric acid. It's the nidus.
Mm.
Once we get into the cardiac side of this thing with MI, heart failure, they've identified the inflammasome with hyperlipidemia as NLRP3 interleukin B. With uric acid, once it gets into the heart, if your uric acid level is 9 or higher, you increase the potential of having a heart attack. Increase potential of developing arterial sclerosis by a 15% increase. So 9 or higher in the heart, you cut 10 years off your life, you increase arterial sclerosis by 15%. So guess what they identified? The same exact inflammasome, NLRP3 interleukin B.
So
Why?
John, can I
Yeah,
interrupt you a second because
absolutely.
I mean, you've laid out a lot of great stuff just right there and right now, but it's like that little kid asking for a drink of water and the guy turns the fire hose on him. But it's my understanding that the hyperuricemia is also a proxy for fructose consumption, that you can
Correct.
increase your uric acid level just by the nature of what you're consuming from a fruit standpoint. And fructose is a little bit of a funny animal in the sugar world because there's this misperception I think a lot of people have that it's a healthy sugar.
Right.
And in fact, it's probably one of the most unhealthy sugars because of the metabolism. We don't have a specific enzyme for it like we do the other sugars. And so it tends to go to the liver and then right into the adipose tissue? Is that
Correct.
okay?
Yes.
All right.
So when you look at it, you start thinking about it, you get this visceral fat. So we increase metabolic syndrome.
Right.
So, it's in this lecture, which we'll get to in a little bit. But I think, when you look at type 2 diabetes, why does uric acid potentially cause these patients to have type 2 diabetes? What does uric acid do to our vascular system? Endothelial dysfunction, oxidative stress. You release XORs. You have these free radicals, but you deplete the nitric oxide. So we know with the pancreas, once insulin is secreted, it requires nitric oxide for the uptake. So if uric acid is depleting it, you're pushing us closer to type 2 diabetes.
Right.
And then you look at, metabolic syndrome, obesity. So I think what I've outlined here is this any surprise now to you, what I'm telling you?
No.
You don't have to memorize any of this.
Right.
If you understand the pathway with hypertension, it pretty much drives into these other disease states. So this is what Steve saw, and this is what I'm going to share with the audience, the Wizard of Coz, and we're going to walk down this yellow brick road, and we follow. In case you don't know what that is in the Emerald City, that is the chemical composition of uric acid. So if you think you knew these characters, let's think again. So we're going to start off with Dorothy Dale. She has psoriasis, polycythemia vera, hyperparathyroidism, macular degeneration, kidney transplant recipient. She likes to do supermaximal exercise, drinks bottled water, intermittent fasting, and the only medication she's taking is cyclosporine and niacin. So now let's break it down. So when we look at psoriasis, actually in France, they have a term called SOUT, P-S-O-U-T, because what they found is that patients that have psoriasis, roughly 30% of them end up having gout. Why? Because as we look at cell turnover, that's what this is all about. Increased cell turnover leads to a degradation and increase of uric acid production as we go through, unfortunately, the Krebs cycle again. So when you look at psoriasis, is this a surprise that psoriatic arthritis and psoriasis increases uric acid production? Not at all. When you look at polycythemia vera, the thing to understand with this is you have an overproduction of red blood cells. They break down more rapidly, which also causes increased uric acid production. and that's why that occurs. But when you look at these pathways, it's really what you need to understand with this. Hyperparathyroidism, hypothyroidism, when we look at this, you're decreasing the excretion of uric acid from the kidneys. This is very common. So, when patients or doctors say to me, how do you find all these gout patients? I really don't look for them. In my practice, I look at comorbidities. In the past, I would have taken an x-ray of somebody's foot and said, yeah, you got some osteoarthritis. That's why you're having joint pain. Now we go down a little bit different path. This is mind-blowing to me. When you look at this slide, so, think of this differently. This person walks into the emergency room, what's going on here? And what they found is that when age-related macular degeneration occurs, it's linked to inflammation, but you can get deposits within the eye of retinal pigment epithelium. So what ends up happening is that is what is required for good vision. They have an increased level of uric acid in these patients. So they find gout in the eye. We were never taught anything like this.
No. So there actually is, well, explain what a tophus is for the non-physician listeners, and then the fact that you're showing that there was a tophus in the cornea.
Yes,
there was. It's astounding.
Yeah. So basically, what they know is the following. Go back to what I said before. When uric acid is produced, we'll go back to that slide. What is it doing to nitric oxide? It depletes it. So the retinal pigment epithelium is required for good vision. You need it for crucial vision. When tophus is present, what does tophus mean? Well, we're taught when we look at something like gout that it's asymptomatic. It just sits in the joint. That's not true. What it's doing at that point is it's depleting all the osteoblastic activity. It increases osteoclastic activity. You destroy the joint, you create osteoarthritis. Tophus, by definition, is basically the conversion of serum uric acid to monosodium urate. Based on normothermia of 98.6, we crystallize at 6.8. But the minute you throw peripheral arterial disease in there where you're depleting nitric oxide, if you have a lower skin temp, for example, of 86 degrees, you'll crystallize into tophus at 4.5. So it's much different, than what we're taught to look for. This is a concept that's missed by many doctors. They just don't understand that correlation. So when we look at, on the eye side of things like optical coherence tomography, this is incredible that they can break these layers down into this. With AI, they're now starting to analyze this much better and see things like uric acid in these structures. Organ transplant, this is wild. So if you're a kidney transplant patient or liver transplant patient, it's a 50% increase in uric acid production because of the cyclosporine that's usually given with this. On the cardiac side, it's a 75% increase in uric acid production. So a lot of these patients end up developing, quote unquote, asymptomatic hyperuricemia. With kidney transplant, a lot of them end up getting gout. So this has not been established, the influence of hyperuricemia in a patient with graft survival rate. They're not sure about that. So when you look at this is wild. Supramaximal exercise. I always joke about this. This is out of Peter Attia's book. So he talks about, that person in the gym that's running on the treadmill 100 miles an hour. They kick their legs to the side. They put a gas mask on, and then they go into anaerobic activity. What are you really doing at this point? Well, you're back to the Krebs cycle. I hate to say this. Your skeletal muscle requirements exceed the production of ATP. You break it down, and what ends up happening is ATP is degraded to, ADP to IMP to increase uric acid production. So they say it's transient, but if you routinely do this kind of activity, this is what's going to happen. So when we look at gout, if I had to bet the farm and say, what's the season of gout? I probably would say winter because of the colder temperatures and holidays, but it's wrong. It's spring and summer, and it's really because of dehydration. So women right now, they found that if they, postmenopausal women, if they're drinking out of plastic bottles, it increases the level of hyperuricemia in these women because of the BPAs. So this is something that just recently came out.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of Stem Regen. Hey Spelunkers, we're thrilled to kick off Season 6 with a fresh new look and the most exciting content we've ever delivered. This season, we're diving deep into the fascinating world of human optimization and understanding. But wait, there's more. We're giving back to our loyal listeners with an exclusive giveaway each and every episode of Season 6. That's right, prizes are waiting just for you. So how can you join in on this fun? Well, it's simple. Follow us on Facebook, Instagram, and LinkedIn. Subscribe to our YouTube channel, and here's the magic touch. Comment, "Let's Spelunk" on any of our Season 6 YouTube videos to enter. Of course, please add anything else you'd like to your review. Don't miss your chance to explore, learn, and win with the Pod of Inquiry. Let's spelunk into the wonders of Season 6 together.
Niacin, we talked, well, cyclosporin, we talked about. Niacin will affect the excretion of the uric acid from the kidneys. And intermittent fasting is wild because I look at things that are in vogue right now. And basically what happens is you're breaking proteins down, because you're fasting. At the same time, the breakdown of, these products eventually produce uric acid. That's what happens with it. So follow. Here's our little list as we met one character. Now we meet the scarecrow. Interesting medical history. Erectile dysfunction, prostatitis, rhabdomyolysis, Paget's disease. He likes to smoke, but he's afraid of catching on fire, so he vapes. He likes alkaline water. He eats Bing cherries. He took Cialis and Viagra, and he's on depot-testosterone, and his wishes, he had a brain. So here we go. Is this a surprise? No. Uric acid on the vascular system, what does it do? It depletes your nitric oxide. So when we look at these medications, sildenafil and tadalafil, what are they doing? They're trying to increase nitric oxide production. Well, in this study, they found that 36% of men had increased uric acid production that had ED. So you start to think about this for a second. Well, if the uric acid is depleting nitric oxide, now you're taking medication trying to increase it, and it doesn't work, what do? Well, you go back to the doctor, and now he checks your testosterone levels. So when we look at this chain, fructose, purines, alcohol, all increase uric acid. They deplete nitric oxide, decrease blood flow to organs. You end up with ED. So now the medications are not working. You go back to the doc, and now he puts you on depot-testosterone. So you start these injections, Symphonate. What is a byproduct of this? Increase uric acid production. Steve, you have to admit, this is almost comical.
It is.
I mean, you look at this and you just say, how is this even possible? Because what you're doing is you're increasing muscle mass. That's the reason why.
Okay.
Prostatitis. Interesting study. 50 men with prostatitis, non-bacterial, What do they find in 25 of the 50 prostates that they looked at? They had uric acid in them. So when we look at a test like PSA, what is it really? It's an inflammatory marker. We know that uric acid is highly inflammatory. So this is something you would never even think is possible. Would you think uric acid would end up in a prostate? It does.
Well, if it ends up in your cornea, it probably can damn sure end up in any other tissue in your body, right?
Pretty much. So when we looked at rhabdomyolysis, you say, well, we really don't see that. Well, yeah, Steve's a surgeon, I'm a surgeon, and the truth is, when we do surgery, it's a potential. If one of these patients ends up under anesthesia and they go into malignant hypothermia, yeah, they can get rhabdomyolysis pretty quick. So what's happening there? Same thing, increased cell turnover. What's the final byproduct of increased cell turnover? Uric acid. So this is a wild slide. And the reason I think this is interesting is, yeah, the Tin Man likes to smoke, but he doesn't want to catch on fire. So smoking cigarettes, nicotine, will actually bring the uric acid levels down. And the reason this occurs is because it competes with the free radicals. That's the whole reason.
Okay.
I don't encourage smoking, so let's vape. So what do we find out about vaping? More craziness. Do we really see lead poisoning today anymore? Probably not, right? Well, yeah, if you vape, what they're finding is the lithium batteries leach out lead.
Wow.
And these kids are now, developing plumbism from vaping. The sweeter flavors that they're marketing in the United States, they're finding actually uranium levels, trace amounts in people that vape. So this is just crazy stuff. This is an interesting slide, and the reason it's interesting is the ACR, which is the American College of Rheumatology, a couple months ago basically said people that have gout should drink alkaline water. What are they talking about?
Right.
So there's a thing called PRAL, potential renal acid load. So as the urine acidifies, you're prone to having gout flares. So that's where this is coming from. If you're drinking alkaline water, you're going to neutralize it. It really depends how alkaline the water is. And even things like Bing cherries, does it really help for gout? Well, the truth is yes, it does. Bing cherries and mangoes contain anthocyanins, and what they find is that it will provide about a 35% reduction in inflammation. So that's an interesting little side note. Can uric acid cross the blood-brain barrier? Pretty much everything I've read has said no, but there are papers that say yes. It's just the concentration is not as much as it is in serum uric acid, but it can go across. This is a study that I thought was interesting because they're looking at brain mass and they're looking at variations. And what they basically found is for a person to have long-term cognitive ability, serum uric acid levels need to be stable. So if there's highs and lows, that's what affects it in a bad way. So the Scarecrow actually received a medical degree, Steve. I don't know if you're aware of this. He went to the Internet School of Medicine, and he did a fellowship after he graduated in Cardio-Rheumatology. Now, this is something that a lot of people may not be aware of, that this is a new fellowship in the United States, because it's what I was talking about before. They're looking at the effects of gout on heart. So this is actually a whole new area. And if you think a little bit of outside the box, you go to a cardiologist and you have a blockage in your heart. How is that visualized? Well, a number of different ways, as we all know in medicine. So let's just say they just look at it with fluoro or ultrasound. They can't tell you what the blockage is made of, but they can tell you it's blocked.
Correct.
So with things like IVUS, intravascular ultrasound, they actually can look at these blockages and bore through them. Well, here's the food for thought. If that blockage is made up of uric acid and you're getting stented and you're not addressing this uric acid buildup in the heart, what do you think is going to happen to the stent down the road? It's going to fail because you've changed nothing in depleting the uric acid burden. So as we follow, our next character we meet is the Tin Man. Cardiac stroke, heart failure, stage 3 kidney disease, nephrolithiasis. He likes to gamble. He eats oatmeal, loves coffee, and he consumes low-dose aspirin. So this is pretty wild. I mentioned this before. Serum uric acid levels of 9 or higher, you will cut 10 years off your life because it will end up in the cardiac tissue. That's actually a DECT image of the heart, dual energy computed tomography, showing the uric acid buildup in the cardiac tissue. This is what I was speaking about before. IVUS is intravascular ultrasound. IVL is interesting because that's intravascular lithotripsy. They're actually using this to smash up plaque in the heart. But if that plaque is uric acid, what is that shock wave actually doing to it? You're mobilizing uric acid. So when we look at things like trauma, surgery, ill-fitting shoes, you can create a mobilization flare. That's the whole point of what I'm saying. OCT, same thing in the eye, optical coherence tomography, angiography. They're able to discern these images much better. And DECT, really shows us these crystal arthropathies any place in the body. We talked about this inflammasome before, NLRP3 interleukin B, same one in the heart, same one in gout, same one in dyslipidemia and cardiac. Oxidative stress, it's pretty straightforward, this cascade. What happens here for time constraints, I'm not going to really get into this too much, but it's all about the inflammatory cycle that occurs with uric acid production. And this I touched on before about the XORs. Once uric acid is built up, you create these cardiorenal diseases, and it's all because of the depletion of nitric oxide when you understand this. Bladder stones, nephrolithiasis, urolithiasis, we talked about this before also. With DECT imaging, when we look at this, we were always taught it's 80% of the time it's calcium oxalate, but when you look at the DECT imaging, here you have 50-50, there you have 80-20. A lot of times the uric acid is the nidus that's in there. Interesting study from the NIH. When gamblers played for money, uric acid increased. When they played for no money, there was no increase in uric acid, definitely showing a connection with dopamine receptors. So that's what occurs. This we talked about before. Once you get to stage 3 kidney failure, your incidence of increasing uric acid goes up roughly 30%. So we look at the exogenous sources of this. It's high fructose corn syrup, purines, and alcohol. Not a surprise. It all does the same thing. Increase uric acid, decrease nitric oxide, insulin resistance, hypertension, decrease blood flow to organs.
John, go back to that one slide a second. Are those equivalent in their effect in increasing uric acid, or is alcohol higher than purines or high fructose corn syrup higher than the others?
Steve, you really love challenging me, don't you?
Yeah.
So you ready?
Yeah.
American Arthritis Research Journal, from highest to lowest. The number one thing that will kick off, now we're talking gout. Gout flare or increased uric acid production is hydrochlorothiazide. They assign a risk factor number of 3.5 to it. Next in descending order is furosemide. So we have two diuretics as number 1 and number 2 position. Third thing on the list in descending order is hypertension. This is not a surprise. Next in descending order, alcohol. So when we look at alcohol, we're taught that beer is the culprit. The truth is it's malted beer. So when we look at the malting process, when barley is open sprouted, it's high in guanosines, which are eventually converted to purines. Next, wine. It's uricose-uric. It brings uric acid down. Hard liquor, neutral. Wow. Well, why are they lumped together? Because they cause dehydration. That's the reason. Next in descending order, as we go down this list, the next thing we see on there, are you ready? Increased body mass index. Then it's high fructose corn syrup. Then it's fructose. So they assign a risk factor number to high fructose corn syrup of 1.8. Next in descending order, as you go down this list, you get to seafood. And seafood, they give a 1.5. Red meat is 1.3. But what is it about seafood and red meat? They use the term umami.
Right.
It's a savory taste. It's actually the glutamates that are in there, and it's the concentration of purines that are present in that food. As we go down this list, it's then low-dose aspirin. Then we get to oatmeal, and oatmeal has 0 nutritional value. So when we look at how uric acid is excreted out of the body, 2/3 goes out through the kidney, 1/3 goes back on GI reabsorption. With oatmeal, they fortify it with vitamins, and the minute they fortify it with iron, it screws up the gut reabsorption. So the oatmeal ends up going to the kidneys and it creates what's called PRAL, potential renal acid load. You acidify the urine, and that's when, cherries come in to neutralize it. Next thing on the list is coffee. And with coffee, what does coffee contain? Methylxanthine. What are the drugs we use when we treat gout? Xanthine oxidase inhibitors. So Japan did a study where they had 153,000 patients that they made drink 4 cups of coffee a day. And what did that do? It prevented soluble uric acid from becoming insoluble in the cardiac tissue, and it did that by 40%, which was great. So that is your list on there.
Well, I could comment a lot about that, but let's press on because this is great stuff.
Okay. So I just hit this 1/3 back through the GI tract, 2/3 out through the kidney. And that's pretty much, when we look at hyperuricemia, the only thing that changes between these two things is soluble to insoluble, and that's your uric acid. And that's what this slide is showing again, 70% to the kidneys, 30% back through the GI tract. Oatmeal, this is just what I was talking about, PRAL. Coffee, this is the study, 153,000 patients. So when we look at the Japanese healthcare system, it's wild because they spend 90% on prevention. I mean, this is an incredible study when you really understand what they did. It's cheap, it worked, and 40% relative decrease in cardiac gout. That's unbelievable. Low dose aspirin, as we talked about before, will kick off gout attacks because it screws up the secretion back through the kidneys. Follow. We now meet the cowardly lion, type 2 diabetes, sleep apnea, metabolic syndrome, obesity, hypertension, GERD. The list goes on and on, as we can see here. So with time constraints, we're going to move ahead. So when we look at this is, this whole pathway that I talked about before with type 2 diabetes. Insulin requires nitric oxide. If uric acid is depleting it, you end up developing type 2 diabetes. Sleep apnea, what do they find with these patients? You're getting a degradation of adenosine triphosphate, ATP, into xanthine, which turns into uric acid. So there's an increased level of uric acid in these patients. Metabolic syndrome, the most important thing on this slide is for every 1 milligram increase in serum uric acid, you increase the risk of metabolic syndrome by 30%. So this is all about high fructose corn syrup. And I think what you'll find more interesting about this is this little green box. The increase in dopamine activity increases uric acid production. Uric acid occupies the dopamine receptors and makes them less effective. So you're constantly hungry. That we talked about before, umami, the glutamates. So we talk about high fructose corn syrup and we joke about the lollipop guild. This is an interesting story because we go back to 1966. And when we look at this, LBJ was in office. He declares a war on poverty. In 66, Takasaki discovers high fructose corn syrup, which is complete poison. Nixon in 74 decides he's trying to figure out how to get reelected. He didn't, that never happened, but his Secretary of Agriculture, Earl Rusty Butts, decides to put high fructose corn syrup in our food. And, this became the corn war and sugar wars in the United States. So when people say they don't consume this, it's really not true. The average American consumes 16 teaspoons a day, which converts into about 60 pounds a year.
Wow.
So, you look at the difference. If you consume 120 calories of glucose, only 1 calorie is converted to fat. With high fructose corn syrup, out of 120, 40 are converted to fat. This is crazy, and it's pure poison.
Yep.
Interesting study. They find that people that have increased uric acid can end up with periodontal disease, but the uric acid actually goes down because this particular bacteria requires it, Prevotella intermedia. Closer look at hypertension. We talked about this in the beginning on that slide. It's all about aldoreductase and endogenous fructose and how we end up down this pathway. Richard Johnson, I think this was a phenomenal study he did. 100 kids, they were all obese, all had elevated blood pressure. He got parental consent from small group of parents. 30% of them said 30 of the parents said, okay, you can put my kid on medication. What does he put them on? Not a diuretic. He puts them on 50 milligrams of allopurinol, and 85% of those kids, the BP came down to normal, showing the uric acid is what's regulating it. So the fructose, chlorine, and fructokinase, it's all about there's no negative feedback. Once fructokinase is stimulated, you keep producing fructose, which becomes uric acid. So this is Yudkin's book in 1969, and you just look at this green box. It's incredible. He put 100 guys on a high sugar diet. And what did he find with this? ATP to ADP to IMP to increase uric acid, oxidative stress, endothelial dysfunction, decrease in nitric oxide, platelet aggregation. That is the key. Mm-hmm. And once those platelets become sticky, we all know what happens. You constrict blood flow. You end up with increased BP. You got cardio-renal disease. 1969, he's talking about this. GERD is interesting too, because what happens is when you're taking medication, your protein pump inhibitors, the proteins are not digested all the way in your stomach. So you're actually building up proteins which increase the uric acid production.
And now a message from our sponsor. One of our main sponsors, Approved Medical Solutions, is running a 5-day cost-free study on the effects of their product Clean Ketones for essential tremors. This is going to be a very beneficial application for this product, and they have demonstrated to me that it not only improves my athletic performance by at least 10%, it also helps with clarity and concentration. So if you'd like to enroll somebody that you know into this study, just see the link below, and they will welcome you in to try this great product.
So that's what happens with the PPIs, protein pump inhibitors.
Don't they also interrupt nitric oxide production as well?
Correct.
So you got a double whammy there.
Correct.
Yeah.
It's just not a good thing.
Yeah.
I joke about your 7-year-old granddaughter's coming over, Steve, and you didn't go food shopping, and there's only 2 things in the refrigerator, a Budweiser and a Coke. What do you give her?
Well, it depends if Child Protective Services are in the neighborhood, because it's pretty straightforward.
Yeah. The answer is neither.
Yeah.
So when we look at these side by side, what do we see? 150 calories for Coke, and that can is actually from Canada. And if you look at it, it's in French, which I actually think is pretty funny. Original taste, Gout, Original. So you're going to get gout if you drink this. That's the joke.
Yeah.
And you got Bud, that's 150 calories. So when we look at soda, there's no GI pass, nothing happens. Out of the 150 calories, 90 of them end up in the liver. That's crazy. Budweiser, yeah, you get your GI pass. And then what happens? 10% gives you your buzz, 92 end up in the liver. The other interesting thing with Coke, if you look there, I circled that. They put 25 milligrams of sodium in there. Why do they do that? You don't quench your thirst, so you're going to drink more of it. And what do we know with sodium? You're going to create endogenous fructose. It's this whole crazy cycle. So they call this the Coca-Cola conspiracy or the Coke war. When it was straight up fructose, you would gain 8 pounds a year if you drank 1 bottle a day. In 1984, where you have that little tiny blue line in the screen, that's where they introduced high fructose corn syrup. So you drink these big gulps, you're going to gain 57 pounds a year. And then we move to the present, 2025, we're back to like 1915. They brought this thing down to a 7.5 ounce can, but you're going to gain 9 pounds in the year if you consume these every day. So you put these side by side,
right.
Fructose exposure versus ethanol exposure. And you asked me before, what's worse? Steve, you tell me what's worse. Look at this. This is crazy.
Well, and John, interestingly enough, a lot of times when you go and have a cocktail, what do they mix together?
Sure. Sugar.
Alcohol and sugar, or
right.
High fructose corn syrup, so it's like the deadly combination.
And you look at this, this is a phenomenal lecture. If you listen to it, it's Dr. Lustig's lecture, and it was done in 2009. He does a phenomenal job talking about this. When you look at these side by side, this is where this came from. It's almost the same, alcoholic fatty liver versus fructose. This is another good one. If you consume 1 to 2 sugary beverages a day, it's equivalent to 1.6 to 2 years of brain aging, respectively. So if
Wow.
you have type 2 diabetes before age 60, you double the risk of dementia. For every 5 years a person lives with diabetes, dementia increases by 24%. Malted beer, it's what I talked about before, open sprouted barley, purines, sedentary behavior. This is what they found with this now. Increases metabolic diseases, including type 2 diabetes, hypertension, dyslipidemia, obesity, metabolic syndrome. Is this a surprise?
No.
No. Crazy study, 45-page paper I read. They took Drosophila flies and they put them on a high purine diet. They fed them yeast. And the reason they picked Drosophila flies is their lifespan is 28 days. So what they found with these flies is that it shortened their lifespan by 48%, and it increased NADPH oxidase NOx, which is related to kidney stone formation. The part you'll find fascinating, which I thought was fascinating, is they did a micro CT of a fly.
Wow.
That's all uric acid that they're showing there.
Incredible.
The diuretics, as we all know what they do, they're all gonna, increase uric acid production and hyperuricemia and gout. The SGL2, they actually decrease uric acid. So they're finding this as a side effect of these medications. Metformin, glucophage. I mean, this is interesting because it's all about PK and AMPD2. What happens. This is how that medication works. So as we follow, this list just gets bigger and bigger. We finally get to the Wicked Witch of the West, tumor cell lysis syndrome, postmenopausal, SLC2A9 allele, paniculitis. She likes to fly on her broom. She's on amlodipine, Elitech, Crystexxa, famous quotes, as we all know what she said to Toto. And so when we look at tumor cell lysis syndrome, why do these patients end up getting gout? Increased cell turnover, degradation of the cells to uric acid. So, postmenopausal, what they find now, they've identified 14 different alleles. So the SLC sequences are all based on sugar and estrogen. So this is women that become postmenopausal have increased uric acid production because the estrogen is uricose-uric. They no longer have it. These are genetic variants they found, that like that 25-year-old kid that walks in your office that, you're looking at, it's usually ABCG2 allele. Paniculitis, in a million years, if I saw this in my clinic, I would never think it's gout. They're finding higher incidences of gouty paniculitis now in the skin. And they really don't understand why. But, when you look at it, it is out there in the literature. Calcium channel blockers actually decrease uric acid. Uricase story is an interesting one. We'll go through it. We're almost getting there, Steve. So basically what happened is our primates had an enzyme called uricase, and their diet all year round were figs, fructose. As long as they had the uricase, even though they had increased uric acid production, it converted it to allantoin, and they peed it out. Then what happened is once the ice age came, and now we have Eurasia, the primates migrate from Africa to Europe. Figs are only available seasonally. They lose the uricase gene, right? Now it becomes a pseudo gene. And the next thing that happens to them, it's survival mode. So now as they consume fructose, they're trying to store it up for the winter. So the fructose is converted to, fat. And this is pretty much what's happened to us. Richard Johnson has actually looked at uric acid levels of primates, many, many years ago, probably millions of years ago. And they now know our uric acid levels are 3 to 10 times more than what occurred initially. And this is just showing the animal kingdom how most of these animals have some version of uricase that eventually converts it to allantoin or other variations of that. Dalmatians are the only animal that can get gout. So with cancer, we look at this Elitech, rasburicase. They use it because of the increased cell turnover, increased uric acid. So the Wicked Witch didn't do well on that, so she was put on Crystexxa. which is pegylated uricase. And as we follow down this list, it just gets crazier and crazier. And we see winged monkeys, Leishman syndrome, HLA-B5801 allele. They fly around all day. They have dystonia. They bang their head. They bite their lips. They're on allopurinol, and their ethnicity is Thai. So when we look at Leishman syndrome, which I've never seen, I probably never will see in my practice, it's usually babies and younger kids. But you look at what can occur, it's pretty wild. This particular allele, it's related to, I have to rephrase that. If you have a patient in your office that is Han Chinese, Thai, or Korean, this blood test has to be done, HLA-B5801, because if you put them on allopurinol, there's an 80-to-1 incidence of Stevens-Johnson syndrome.
Wow.
Or these other diseases that are on here that can occur, toxic epidermal necrolysis. So ever in front of you is a Pan-Asian patient that you may think has gout. You can't just put them on allopurinol. You have to do this blood test before to find out. I routinely run it when I have those patients. So as we follow, the list is bigger and bigger, and we finally meet Toto. He has no medical problems. He runs around all day and barks, and he's on no medications. And the wizard, when we look at this, and here's the question as we pull this curtain back, is it really asymptomatic hyperuricemia? It's a question to think about. 20% of these people will develop gout. Right now in the US, we have 14.28 million people with gout. So as we pull it back, is it asymptomatic? You decide. So when I look at this quote, to treat or not to treat, that's the question. That's a joke, of course. It was actually a paper written, and that was the title of the paper, which I thought was pretty wild. How do you diagnose it? We're just looking at blood tests pretty much. Well, if you look with ultrasound, what do you actually see? I'll interject real quick on this slide. If a patient's going for uric acid test, should they be fasting? Yes. Should they consume any soda before the test? No, it's going to shoot the uric acid up in 30 minutes. Should they exercise the morning of the test? No, because it's going to increase uric acid production. So when we look at this, what does ultrasound show us? Real quick, we'll see this kind of stuff. We'll see clouds, hypoechoic clouds. We'll see snowstorm patterns. You'll see urate interposed in there. It just hasn't coalesced into a tophus at this point, but you have sludge in the joint. And what is that sludge doing to things like lubricin? It depletes it. What do we know happens as this progresses from hyperuricemia to gout in the joints? They become stiff. So, what is it doing at that point? You're depleting all the osteoblastic activity. Your bone density is being depleted also. Your T-scores are going down. What don't you? Well, this is something I'm working on now, shear wave elastography, looking at the joint fluid. In theory, it should be getting harder as the disease progresses because that's what happens. These joints become stiff. Right. So shear wave is a simple principle. You're taking a drop of water and you're dropping it into a glass of water. It's the radial waves that go out that penetrate through tissue. And, is that soft or hard? That's what this is telling us. What don't you see in hyperuricemia? You're not going to see Martel's sign, which is, complete bone destruction. You're not going to see hypervascularity. You're going to see that in gout in the first 48 hours. You're not going to see what's called a double contour sign, where the uric acid is in the cartilage and you get that double convex arc. So these are things that you're going to not see. Lubricin we talked about before, because what it does to the fluid, and this apoprotein. So treatment parameters. Technically, using drugs like allopurinol is considered off-label, but if you go down a holistic approach, it's things like quercetin, DHA, vitamin C, luteolin, and chlorella. That's out of David Perlmutter's book. Is diet important? Well, NYU did a study, 19,000 patients on the DASH diet. And what happened there? Best they could lower serum uric acid was 0.5 to 1 milligram per deciliter being on this diet for 1 year. So what I say is the following. If you have chronic gout, diet is really not going to matter. It's the triggers that trigger it off. If you have hyperuricemia, I encourage you to follow something like this so it doesn't progress. and here's your purine contents of food, low, moderate, and high. And the conclusion is the following. Do we allow Casey Jones to drive this train and crash it? And then we run in and practice medicine 2.0 where we try to fix everything? That's really the thought I want everybody to think about. So when Dorothy clicked her heels and said there's no place like home, I say help open my eyes. That's pretty much it, Steve.
Well, John, that is like I said when I first heard your lecture a month or two ago down in Atlanta. It's fantastic. There's so much to unpack there, but I think one of the things that I would kind of summarize this whole thing is that if you're going to somebody and they're not looking at your uric acid level, you probably ought to find another practitioner if you're really serious about your health. And your question is hyperuricemia asymptomatic? And that's like saying there's a fire burning in the house, but the house hasn't burned down yet. Is that really a fire? And the answer is it is definitely something that you want to I think pay close attention to. The other thing that I took out of this is that it seems paradoxical that a lot of the drugs that you would use to treat hypertension increase the uric acid levels, it's just a feedback loop. You're just like the dog chasing his tail.
Sure. So when you're spot on with everything you've said. So there are two things that occur right now. There are a lot of doctors that are out there that are still treating this as a flare disease, and they're just doing flare management for, let's say, gout. But when you read something like David Perlmutter talks about, we actually have like CGM meters for diabetes.
Right.
They actually have handheld uric acid meters, which we have in our practice. They're cheap. It's like a $30 meter, and you get 50 tests. At first I said, wow, that's, something to really think about, because
Right.
you really don't understand until you go through a lecture like this how much this is mediating. It's this metabolic dysfunction that it's creating.
Right. Right. It's so fascinating that medicine has, well, it's starting to evolve now, but it has been I'm going to look at this one little pathway. I'm going to look at this one little symptom. And there's all of these myriad connections between these pathways, and nobody's really making the connection. Now they are starting to, much more than like even 5 years ago, 10 years ago. But 20 years ago, if somebody had a high uric acid and they came in and you ask them, well, have you had any gout attacks? And they say, oh, no. It's like, okay, great. What else is going on? You know what I mean? It was like nobody gave any concern that they had an 8.0 or a high reading. It's like, well, you didn't have a gout attack, so you're all right.
So Steve, where you get thrown monkey wrenches or things like this, one day I'm in my clinic and I walk in the room. It's an 85-year-old patient. He's having a gout flare. He's tophaceous. He's ulcerated. And I said to him, do you know what your last uric acid read was? Oh, yeah, it was 2 weeks ago. It's 4.5. And I'm saying in my mind, yeah, sure, right. Are you taking medication? Yeah, I'm on allopurinol. And, I wait 2 weeks. I look for epidermal desquamation. So we know the attack is over now, right? It's fascinating when you think about it. We do a blood test, and what does his uric acid come back? 4.5.
Right.
So how the heck was this guy having a flare at 4.5? What did I miss? He has peripheral arterial disease, what I mentioned before. So if we solely look at lab values and say, well, LabCorp, Quest, or whatever lab it is, it says normal is 4 to 8, and this guy's at a 4.5. How is he having a flare? It's because of the temperature. And there's a debate in the United States what our core temperature is. It's no longer 98.6. It's probably more like 97.1. So I actually do an adjustment. So what I'll do is, let's say I measured your core temp and it's 97.1. What I'll do is I'll say 98.6. We know crystallization of uric acid is at 6.8. I'll then, do a ratio. 97.1 is to what? It will come back 6.1. What's the next thing I do? I take the lower skin temp with a digital thermometer, and I can predict what this person's going to crystallize at.
Right.
So it's a different thought process.
And that's probably why the first metatarsal phalangeal joint is the most affected joint in the body with gout because of the temperature.
50 to 64% of the time, it will be the first MTP. The hind foot will be 24%. And then your auricular areas in the ear are higher. So the orthopedic world actually is developing protocol, if they should cancel surgeries and based on what. So what
Right.
they're actually looking at is uric acid levels, but what they're not taking account in these studies are the extremities, where it's colder. They're not looking
Right.
at temperature. So
Right.
that's critical, to understand that. And
Yeah.
you really want to dumb it down because this is how I explain it to internists. Not that they're stupid, but I know I'm only going to have 5 seconds. So I got a phone call one day and they said, "Hey, you put my patient on allopurinol and their uric acid's, 4. Why'd you do that?" "Well, doc, here's what we got. We got 2 beakers. One's got hot water, one's got cold water. And I drop a stick of butter in each one. The cold
Right.
water is
Right.
PAD."
Right.
"Oh, got it."
Yeah.
They get it.
Right.
They understand it.
That's fantastic. I tell you what, John, I admire people like you that have such a command and passion and that go into an area like this, and then you're able to break it down so us lesser mortals can kind of understand and see the importance of it and everything. But I truly am very grateful that you came on and shared this because your level of expertise
Thank you.
is phenomenal. So thanks so much.
Steve, if you have me on again, I can guarantee you it will be a different lecture and it'll be new information.
It always is, isn't it?
Yep.
Thanks again.
All right.
As you know, I'm passionate about learning new ways to address health concerns. Moreover, before I recommend any treatment or supplement, I always try it on myself. Today, I want to share my experience with Troche. I have investigated other phytocannabinoid formulas and found that, in general, they were not consistent or reliable in their results. What impressed me about the Troche delivery technology is that each rapid-release tab is engineered to provide fast-acting, long-lasting, reliable delivery of phytocannabinoids to support your health and well-being. Many physicians understand the importance of using phytocannabinoids for physical discomfort, sleep issues, and mood. But if the formula is not reliable, most patients will give up, never experiencing the real benefits. I put this to the test on myself and actually tracked my progress. This graph shows my results for reducing stress. Troche is so serious about how well their product works, they partnered with People Science to provide the Troche Tracker health assessment application that lets you monitor your progress and works with you to accomplish your wellness goals. If you are a patient, click the link below and the patient button to register for Troche Tracker. Assess your baseline health metrics and receive a free Troche sample in addition to getting preferred patient pricing on all products. If you are a clinician interested in adding Troche to your practice, click the link below and then the clinician button to register for a wholesale affiliate account or go to the link above. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.